Welcome to the United Leukodystrophy Presents Physical Therapy with Jennifer Keller and Dr. Zackowski from Kennedy Krieger Institute.
Hi, everyone. Thanks for coming. Jen and I are going to give a presentation today to provide you with some strategies from both an occupational therapy and a physical therapy perspective. Many of you may have heard a presentation from us in the past. We try to change it up every year a little bit, so we hope you get something new. And today we're kind of emphasizing some new strategies that we hope that you will find helpful. You'll recognize that much of our work comes from the adrenomyeloneuropathy group, but we've tried to extend some of the information so that individuals, if you're listening and you have other types of leukodystrophies, we hope this will still be helpful. And we will definitely have time at the end for questions, and you can put in questions on the side too, if you'd like to, if you think of things as we go on. Okay, go ahead, Jen. So as you know, all of us, this is a completely new scenario. We're sheltering in place in terms of, the pandemic has changed our perspective on so many things, right? We've all been told to stay home. All our activities have been canceled or slowed. We can't go to the gym, which I'm hoping many of you were. Groups like the YMCA have been closed. Even rehabilitation clinics and medical clinics have been closed. So your lifestyle, I could imagine, has become a bit more sedentary. At least I can say, even from my perspective, it's just different. And this is not something we've ever planned for. So we want to give you this presentation in light of this kind of new reality, right? So your regular sources of activity and motivation have been changed. And we have to keep that in mind as we move forward. So your body may feel like the form of a chair, as mine does. I have to pause for a minute when I stand up to even kind of work out the kinks a little bit. And you might feel like that too. Okay, go ahead. So your balance and walking might also feel a little bit worse. Okay, so keeping all of that in mind, changes in the CNS can really make moving difficult, right? So whether it's AMN or other leukodystrophies, it really, the central nervous system has been altered. And so doing practical things that you have done in the past might be very difficult, from just walking to going to the grocery store, walking up and down stairs, being able to walk with loved ones and hold a conversation might even be difficult, kind of doing two things at once. So we want to provide you with some ideas of what can you do for this. And we think, first of all, we want you to think about what it is you want to do. Go ahead. So we know that in AMN, for example, there are very specific central nervous system changes, right? The primary motor pathway and the primary sensory pathways have changed. And what that means is that there's a variety of symptoms that we may expect. Can I see the other side of the slide, Jen? Okay, so there's sensory loss, so vibratory changes that in AMN occur first in the feet and more rarely in the upper extremities or the arms. There is progressive weakness from the legs up to the arms, and this weakness may be in part because of the changes in the motor pathway that carry information from your brain to your arms and legs, but it also could be from secondary, what we call secondary disuse, right? So weakness that occurs because you're now doing less, because it's more work to do the things you were doing before. Another really common symptom in AMN and in other leukodystrophies is spasticity. So spasticity is this inability to control your arms and legs, and you feel kind of a catch or a tremor, or so that it's hard to make movements smoothly, especially if you try to move quickly. Many of you may have difficulty with walking or difficulties with balance. Now, we will focus today on walking but we will try to hit on some other areas, understanding that walking may not be your particular symptom that you want to focus on. But we, in much of our work with AMN, we have found that walking is a primary goal with many people. And many of the clinical trials use walking, and specifically walking speed, as a measure to determine if a new intervention is working. So we're going to work from that perspective for the next several slides. Now, we know that slowed walking is associated with, it's more energy. Because it's more energy, it may affect the choices you make and what you want to do each day. So this could, in turn, affect your quality of life. And it may lead to secondary complications. If you move less, now you may end up feeling stiffer. You may end up gaining weight. All of these things can lead to complications that started out just because of these changes in walking. But if you might want to think about, I want to walk so that I can, and then we'll move forward from there. So go ahead and keep going forward, right? So the goal of many of the interventions is to address key impairments. And so by interventions, just to clarify, many people will think of medications, because that's so often the way our medical system is really focused on medications as interventions. But I want to really encourage you and emphasize that interventions can come in terms of rehabilitation that don't involve medications, or maybe complementary to the medications that your physician gives you. And so those are the kinds of interventions that we'll talk about today. And when we talk about impairments, for the purposes of this talk at least, we will be talking about things like strength and sensory loss, and your ability to walk a longer distance, and your balance. Those are what we're calling impairments. And so walking in particular, or just increased activity, will, we think, revolve around three main parts. So one is what we call biomechanics. And so this is kind of how your body moves with your bones and your muscles combined. So that will incorporate strength or weakness, as well as flexibility. Cardiovascular incorporates, how long you can do something. So what is your endurance for a certain activity? And then neurophysiology, that part is really taking into consideration sensory changes that might change, as well as brain changes that can impact your balance. All three of those things, or four of those things, so really strength and flexibility, I would combine, endurance and balance, all can affect how active you are and can affect your walking. Okay, go ahead and go to the next, keep going. Okay, so, and keep going so I can see more of what right, there we go. So when we talk about gait, or that's another word for walking, so walking in AMN or other leukodystrophies, right? What we find in AMN specifically in our studies is that weakness is the most prevalent feature that affects a person's ability to move. So weakness, we know now, affects both men and women, and that this weakness can vary from person to person. And that the good news is really that although we know that weakness is an integral part of what an AMN experience will be, whether you're a man or a woman, we also know that we can change strength. And we've shown this in a study, and we'll show you some data as we move forward. But if strength is changeable, then we were hoping, and we found, that walking is also changeable. Okay, go ahead. So how do we know this? Let me show you a little bit more about the studies that we are referring to here. You can go one more click forward so I can see that. There we go. So if we talk about range of severity, Jen and I and several others have published this study where we took a large group of individuals with adrenomyeloneuropathy, both men and women, 142 of them, and we measured a lot of impairments. So remember, I told you sort of strength, sensation, balance, endurance, those are all measures of impairment. We measured a lot of impairments in a large group of individuals with AMN, and we found that strength was a really important feature, so important that if we group people based on the amount of strength or amount of weakness they have, then we can stage people based on that one impairment. So go ahead and And this, I'm going to show you here. So this is the data. If you look on the bottom, you'll see these are the different groups. So we had what's called a control group, or just individuals that don't have AMN, but are age and gender matched to the people with AMN. We had a group that had what we call mild weakness, a group that had moderate weakness, and a group that had severe weakness. And then we divided those group up by men and women. And what you will see is that, I guess I can't show you because I can't use my cursor, but that weakness goes down as you get to the more severe groups. Now this is because this is how we've chosen to stage this, right? We've chosen weakness, and we found that there are specific groups of individuals that have this different amount of strength or weakness. And I'm gonna show you how this can relate to other features. So this is a kind of a very busy table, but I want you to notice that there are 3 columns. There's a mild, a moderate, and severe column. And so that relates to the amount of weakness, right, that individuals have. And I want to show you that we had a large group of individuals with mild weakness, a large with moderate, and a very much smaller group of individuals who had more severe weakness. And I will show you that many of the people that were in all 3 of these groups used a walking device or didn't walk very much. And they had disability based on a rating scale that physicians use called the EDSS that really increased from, in the severe group, the EDSS was a much higher number than in the mild group. Okay, if you go to the next slide. Now, this is even a busier slide, but if you hang in there, the whole point of this is to look in these 3 green boxes. So I want to point out 3 impairments that I thought might be interesting to you. So when we look at how well a person can feel vibration, and vibration we know is very important for balance, what we find is that the men start out with pretty poor sensation right away. And even the men who had mild weakness had pretty poor sensation. Almost equivalent to what the men in the moderate group had. And although what's different is that the women in this mild weakness group had much better sensation than the men did in that group. And their sensation, though, progressively worsened as their weakness worsened. If we look at the second green box down, this is spasticity. So that inability to kind of control or move smoothly with your ankle, what you will see is that spasticity seemed to be a much bigger problem for men than for women in all 3 of the weakness groups. If we look at walking speed, which is the third green box down, what you will see is that walking speed really affected men and women profoundly, even in the mild stage, mild, moderate, and severe stages. So this is how, as a scientist, we get to understand which impairments affect people. But it's really important for you to understand this, because this is how your physical therapist or your occupational therapist or even your physician may better understand or be able to understand what your progression might be like and how we can address the issues that you have right now. Okay, let's go ahead and go to the next slide. So when we put all of these impairments together in a big group, we found that hip flexion strength, so that ability to lift your knee up to go to a step, for example, that's your hip flexor muscle. And hip flexion strength was the most important impairment that really impacted walking speed for individuals with AMN. Okay, go ahead and go. So in AMN, we found that staging based on how weak a person is provides a way to characterize the severity of common deficits in body function. All that really means is in the different impairments that we know, we understand that weakness is very important, and that tracking your weakness might allow a physical therapist or occupational therapist to better intervene and provide interventions that will help you be able to do the activities you want to do. Okay, go ahead. Okay, so now we'll get to the practical parts. And I think, Jen, you're going to take it from here, right?
Yeah, thanks, Kathy. That's great. Exactly. So that framework that Kathy talked about, that really helps us to plan what kind of interventions would be best suited to meet your needs. But there's a lot of ways that we can go about this. And I really like this sort of organization or this question. So what can we change? Can we change something about ourselves? Can we change something about the strategy that we're using? Or can we change something about the environment that we're moving through in order to maximize our ability to participate in our lives? So we're going to start off with something that we can change about ourselves. And as rehab therapists, I think we know that exercise is medicine. So any, strong wellness-based program or exercise program is going to incorporate all of these things: aerobic, flexibility, resistance, or strengthening, and balance, as well as just increasing your general overall physical activity. So like, how active are you throughout your day? But where you start, that can be a little bit hard for people to figure out exactly. So as therapists, we also think that it's important to know who's your PT or OT. And in this time, it might be who's your tele rehab therapist, because a lot of us can't get out to the clinic, but we've been able to, at least in my job, we've been able to reach a lot of people through telemedicine now. And I want to just give you one way you might be able to find a physical therapist that's near you. The American Physical Therapy Association has a website. It's the apta.org. And on it, they have something called Find a PT. So it allows you to search for a physical therapist in your zip code, and you can specify that you want someone who specializes in neurological disease, and that might just be the best option based on having a leukodystrophy. But you can also choose, if you're looking for your child, a pediatric therapist, or if you're in a more rural area where you might not have that choice, you can look at least through a longer list and select people who say they have experience in a similar area. We think it's really important to go to a therapist for early on in a diagnosis, because even if you don't have any symptoms, we can find a good starting point and make a good wellness program to help prevent things like the disuse type of weakness that Kathy talked about at the beginning, or also, give you ideas for how you might prevent or maintain your activity level throughout the course of your disease and throughout your life. There are some tips that we think are important for finding the right specialists. You wouldn't just go to anybody for physicians. I think it's equally true for your rehab PT or OT. You can look for someone who specializes in neurology. Like I said, if you can't find just neurology, you might ask how many people someone has treated with MS or neuromuscular disorder or spinal cord injury. Similarly, if you have a university center nearby, they just tend to be more familiar with rare diseases. And so you may have someone who's and maybe not had experience with your disorder, but has experience with someone else with something similar. And then you really want to ask good questions. You want to have good communication, good problem solving, and feel like they are looking to help you solve the problems that you want to solve. You really want to ask, what is it that you want that therapist to do to help you do that you want to do better at? And so that brings me to, what do you want to do next? And I think we always really hit this, but for AMN in particular, or just even if you have weakness in general, a progressive resistance training program is really where you need to start. And ideally, through that rehabilitation evaluation, you would find out that you're weak, but not just weak, but weak in specific muscles. One muscle might be stronger on one side of the body than the other, or maybe your hips are weaker than your ankles, something like that. So you know where to start. We've done an exercise study for women with AMN, and we had them exercise for 12 weeks, 3 times a week at Curves gyms, which are a worldwide gym. They went to a gym close to them, and they performed 30 minutes of exercise 3 times a week for this 12 weeks. And they had to increase their resistance over time. So the number of repetitions and the effort with which they were performing their repetitions. And what we found is that, as Kathy said, walking improved. So what I'm showing you here in this graph is that in blue are the group of women with AMN, and in red are the age-matched healthy control group. And this is a pre-test, so the values on the left are before they did the exercise program, and the values on the right are how fast they were walking after they did the exercise program. And what you can see is both groups improved significantly in their walking speed by more than 0.1 meters per second, which in a lot of populations, that's been shown that people really say that that makes a meaningful difference in their life. But also, the women with AMN improved as much as their age-matched control group. And we didn't know if that was possible, if women could improve as much as people who didn't have AMN. And that's a really significant finding in terms of it should give everyone, I think it gives people, more hope that you can make a significant change in your activity in a similar amount of time. As well as seeing changes in walk speed, we saw an improvement in hip strength. We were hoping for that as well, because even though this exercise program is more of a general cardiovascular program that allows you to do strength training, it didn't necessarily specifically focus on the hip flexors, but we know that the hip flexors are very important in AMN. So it was good to see similarly that the AMN group had a significant increase in their strength, which is about here only about 2 pounds, but it went along with having this improvement in their walking speed. So how do you do a resistance training program? So Kathy talked about this mild, moderate, and severe grouping. And maybe you've had your physician or your therapist test your strength, where they push down on your leg and see how strong you are. And that's usually done on a rating scale. So we say a 5 out of 5 is full strength. A 3 out of 5 means you can move your leg against gravity, but you can't take any resistance. And maybe a 1 out of 5 is somewhere where your leg has to be supported on the mat table or on your bed, and you're just able to activate that muscle. You can make it contract, but you can't move your leg. So this is one way that you might think about grouping where along a spectrum you might be strength-wise. Of course, we like to use a dynamometer, which gives us a number in pounds of how strong someone is so that we can see a change. So what I'm going to show you in the next slide is how one way that we like to apply that strength framework for looking at AMN. So one way that you might do this is it's pretty easy to set up even for yourself. Measure out 25 feet and walk as fast as you can and see how long it takes you. And here I'm just showing you 2 individuals, a man in blue and a woman in orange, who could complete this walk in 5.5 seconds or just about, which is pretty close to expectations. Some people can do it a little bit faster than that without who don't have any symptoms. And these if I do the calculation based on our framework that we designed, their hip flexor strength correlates with about 53 pounds of resistance for the man and 37 pounds of resistance for the woman. And if you were to say, do an exercise strength training program where you were to lay on your back and pull your knee towards your chest in order to strengthen that hip flexor, if you were at this level of walking speed, you should be able to have a significant amount of resistance against you at that time. So you might use a leg weight, or we tend to use resistance bands. So you would use a high level of resistance band, one that's more tense and could give you a greater workout. If, however, you did this 25-foot walk test and it took you more like 8 to 10 seconds, we would estimate that your hip strength is around 25 to 35 pounds. And you might want to start at more of a lower resistance level. So you might be able to lay on your back and pull your leg towards your chest, but you might have to use a lighter weight band or not as many bands to resist. And I'll talk about this a little bit more as we go forward. And lastly, some people might walk this 25 feet much slower, more like 25, 26 seconds, like some of the people in our more severe category. But they should still be able to do exercise, but maybe in that gravity eliminated, like easier category that I talked about. So where you might lay on your side so that gravity isn't acting against you, so you don't have to lift your whole leg up, but you could slide it along a table or over a bench and work up with lighter weight bands till you could get to the next level. And where might you do this type of an exercise program? So we think doing a program like this, we did it with women at a Curves gym, and that's a possibility. Although, of course, in this time of this pandemic, going to most of the gyms are closed, and that might not be an option. We have also done a study for people with multiple sclerosis and healthy controls, where we used exercise resistance bands, and they did the same paradigms, the 3 times a week, 30 minutes a time. They came into the lab in small groups of like 2 to 4 people, and they increased the resistance and their number of repetitions over this 12-week period. And what we found was that we saw a really significant increase in strength and in walking speed, like I showed you in the Curves program. But we also were able to publish these results in a video journal. So it's called Jove. And in it, what you can see is we have been able to lay out the handout that we use to monitor people's effort levels and how much resistance we gave in bands, and then also give a good description of how people might set this up in their own clinic or in their own community, how to set up the exercises. So here I'm demonstrating with our subject how to pull their knee towards their chest for the hip flexor, how to use a thigh cuff to attach the bands so that they don't pull on the knee. Often we have to set things up and we do it between the ankle and the knee, but that can be stressful. And here I'm demonstrating how maybe if you're not as strong, you could eliminate gravity in this effort and you could pull your knee towards your chest, but use a support like a pillow initially so you could get stronger. The video goes on to show other exercises that we did. We focused on hip strengthening, so the hip muscles as well as the quads and the hamstrings. So we did this in a clinic, and we've shown that we can improve people's strength, and we've done it at the gym. And I will say that we've given it to people to take home to do as well. And I think it's hard to follow up at home, to stay motivated, and also to know when to progress yourself, how much resistance to use, and then also to do it and not get hurt. So without any supervision, someone to monitor how good your form is and if you're doing the exercise correctly. So I'm hopeful that maybe this tele-rehab approach might be the next best step for a program like this, so that you could have supervision for an exercise program, but not have to travel to a clinic 3 times a week, which can be a large burden, and maybe make it more accessible to people throughout the country or the world, and not be as limited. From there, we're going to move on to about the strategy you can use. I think, Kathy, you're going to lead us through this.
Go ahead. You want to go to the next slide? Okay, so I think we're gonna talk about strategies that you can use, and we've been really harping on this idea of weakness as a really important component that you need to address. And I'm gonna try to work in a few answers to the questions I'm seeing on the side. One person asked if you can generalize this information from AMN to other leukodystrophies. I think in general, that is fine. You can do that. What I would recommend is maybe taking the paper that we've published and bringing it to your PT, your OT, or your physician, and showing them this, and then they can evaluate you and see if you fit the characteristics that we have described in that paper. And if you do, then they can kind of move forward using that staging that we've talked about as a way to track how you do and how they might intervene. Going back to the slide, other strategies, sensory changes are really important to keep track of, and they can be compensated for by changing how you do some things. And also fatigue is a really common problem, and that can be changed with something called energy conservation tips, which I know sound very practical and obvious, but I will tell you that it's very helpful to ask an occupational therapist to explain some of the energy conservation ideas they have, because although they're not rocket science, so to speak, they're things that are really good reminders for all of us to try to work into our daily life, especially if fatigue is a big problem. And then, of course, fall prevention is very, very important to keep track of, and try to figure out why you're falling and what are some things you can do to modify your situation so that you have a lower risk of falling, because we don't want you to get hurt, right, or hit your head if you fall. All of these things just make it even more complicated, make your situation more complicated. Okay, go ahead and go to the next. So we did an exercise intervention, and we targeted hip strength. And I want to share with you a couple of things that we found about strength and about sensation that I thought were really interesting. One, we found, this isn't, this might be obvious to you, that strength worsens with age, right? And what you can see on this left graph, if you look on the x-axis, that's age, so age gets older. And then on the y-axis of that left graph, you can see that that's strength. And so what we're showing is that the open circles are the people that don't have AMN, and the black circles are people that do have AMN, and that in the early ages, around 40 years of age, you can see big differences in strength between those individuals with AMN and controls. But as you get older, even around 60 years of age, you can't really tell that much of a difference. So strength, we know, worsens with age. So if you have AMN and you're aging like all of us, those are two things that to keep in mind that will be kind of moving in the similar direction. So it's really important to keep that in mind so you can, I guess, fight it or try to maintain your strength as much as possible. Now, we wondered about vibratory sensation, which again, I want to emphasize, the reason we push this idea of vibration sensation is because it's linked so closely to balance. And what we found is that regardless of age, sensation seems to be worse in individuals with AMN. And you can see that again if you look at the black circles there on the right versus the open circles. The black circles worsen or always higher up, meaning vibration sensation is worse, and regardless of age. So strength is changeable and is something that changes with the disease as well as with age, but sensory loss kind of persists and is worse regardless of age. Okay, so now taking that information, we want to optimize your safety. And there are a lot of things you can do. I'm an OT, so I tend to think very practically in terms of what can you change in your home environment to optimize your safety. And again, these are obvious things, but they're just good reminders. So turn on the lights before you walk into a dark room, checking your skin integrity. So even just looking, if you lose, as we know in AMN, you lose sensation in your feet first. It's what we found is some people will actually have sores on their feet and not even know it because you can't feel it. So at night, just check your feet, check your legs, and make sure there's not a new gash in there that you could that you didn't recognize that you had, and so you can take care of your skin and avoid infection. Wear proper shoes. You don't want to have throw rugs on the ground as much as possible because they're just a tripping hazard. You want to think about how your house is laid out and make sure furniture is not making it difficult to get from one room to the other. And you want to use good body mechanics. So you want to, don't always lean forward. You want to be able to use any walking devices with good body mechanics. Okay. What strategies can you change? So there are a lot of things that you can do. The first thing is, and something that I feel like I'm always trying to even remind myself, is to take your time. So you have to recognize that when we're in a hurry, we're more likely to make mistakes, and we're more likely then to have a higher risk of falling. Simplify the movements you're doing. So for example, if you're going to cook a big meal, maybe you could organize things. So simplify the tasks. So you do some of the hard things first, you take a break, and then you do some of the more, the simpler things after that. A biomechanics strategy you can use, just even when you're standing, stand up, wait a few seconds to ensure that your base of support and you're feeling stable. And once you're stable, then you can take a step forward. Do one thing at a time. So I know this idea of multitasking is very compelling, right? We get more done. It allows us the idea to get to be done with some of our tasks. But the more that we try to do multiple things at once, the higher risk of falling again. So try to decrease it to one thing at a time. I can tell you that evidence has shown that our brain can't really multitask. What your brain does is it goes from one task to the other and goes back and forth to try to fill in the gaps. But your brain can really only attend to one thing at a time. So we should be practicing that. Now if you could go to the right side, just make sure that give yourself permission to accept help. And that people, if you want, people ask you if they can help, think about ways they can help you in order to give you a little bit more time to do something, or a little bit more energy, because you didn't have to do all of the parts of it. Okay, go ahead. All right, what can we change about our environment? I think Jen, you and I are going to go back and forth for these. So go ahead to the next slide. Go ahead, I think you're first.
Okay, so I think especially in this time, personally, I've now been working at home a lot more, and I don't have the same desk chair. So I think trying to make sure that you have good posture so that you don't end up with maybe shoulder pain from having your hands too high on the computer, or if you find that you lean on furniture when you're standing, say when you're cooking in the kitchen, maybe you tend to shift your weight to one side, and so you're getting one side to be stronger and the other side may be getting weaker. You may be developing different faults that lead you possibly to trip over your toes a little bit more often. There are things that you can do about your environment to adjust for these things.
And other things that would be important is, even if you have a care partner and your care partner may be struggling to help you out of a chair or help you to get from a chair to bed, are there ways that you can set up your environment so that it's safe, so that you can avoid falls? Okay, so things that are really important is to set up your environment, right? So even your posture as you're doing these very practical tasks are really important. So for example, sleep, we all sleep, but having the right alignment as you sleep will, turns out you'll have better rest and you won't have as much pain or stiffness in the morning. So make sure, as you can see in the picture, have a pillow for your head, but not too tall of a pillow, right? Because you don't want your head to be facing upward. You want your head to be really along that horizontal plane like the picture's showing. Make sure that your bed has the right amount of stiffness so that your spine is kind of horizontal as well as you lay on your side or even lay on your back. Make sure that your shoulders are aligned in terms of, you don't want to always have them up high, close to your ears. You want to try to remind yourself to relax your shoulders and pull them back. Make sure that your neck alignment is good. So many times I see patients who, when it gets hard to move, you start leading with your head, and then you look in a mirror, and if you show them, they'll say, oh, I didn't know that I had my head up, or I had my neck in a really strange position because I was straining to do things. Take time, again, to have the proper alignment. Start from a really good base, and that should help you in moving. But if we can slow things down and move a little bit slower. Okay, and go ahead, Jen.
So I think along those same lines is just how important it is to maintain your range of motion, which comes from being flexible or stretching. So, side bending for your neck, if your neck gets stiff, just simple, range of motion for your neck is important. You can work on your back alignment. So, sometimes when we had a diagnosis or we just are getting older, we stop getting on and off the floor as much. Sometimes just laying on your back on a hard surface is a good way to work on your back range of motion so that you can have a nice upright posture. Two very common things for our AMN population are having a tight hip flexor. So while we really want to strengthen those hip flexors in order to walk faster, if you spend a lot of time in sitting, they can also get tight. So in this picture here, you're actually stretching the one that's down over the end of the bed in order to stretch out the front of the hip, because you need to have enough range of motion to be disabled to take a step forward and have the other limb sort of trail behind you. Otherwise, you would take kind of short steps. Another very common complaint that we hear is foot pain under the foot, and that can be from plantar fascia pain, typically maybe runners would get, but it can also be from spasticity, and it can be from reduced range of motion or from weakness in the lower leg. And some of these can be simply addressed by stretching that we would do for this kind of an injury or a pain. You can stretch your heel cord and then doing some plantar fascia stretching. But other times what we really need are some sort of orthotic or brace support. So simply having a really good, if you have a change in your foot position, say you have a really high arch, it can be supported by an orthotic that you can slide in your shoe, and that can give you a better starting point for walking. And then if you're having trouble clearing your toe because of lack of range of motion, you can use a brace similar to something like this, where it helps set your ankle at 90 degrees. So you can't point your foot as much, but it helps you clear your foot. You can also use a brace similar to this at night in order to stretch. You can add straps to the sides that can help you work on increasing your range of motion with time.
Jen, do you want to comment? There was a question about casting for immobilization. Maybe this would give you a good place to comment on that.
Yeah, so I think when people lose a certain amount of range of motion, sometimes the simple things that we first try, like trying to stretch on your own, are not as effective, because in order to actually lengthen a muscle, it requires prolonged stretching. And typically we only stretch for about 30 seconds at a time. Maybe we can use a brace like this overnight, but sometimes that also cannot hold us in a good position. So an alternative might be something like in conjunction with your physician using a medication. We would often do something called serial casting. So we would cast someone with their foot with as much range of motion as they can tolerate, maybe just to back off a little bit for a week at a time. And then at the end of a week, we would take off the cast and stretch again. And typically the muscle has lengthened during that time. And so we can replace the cast with a slightly greater stretch. And this can go from somewhere from 3 to 6 weeks till you achieve the range of motion that you're looking for. I think it's very effective. It's just some things that you have to consider, and it's worth discussing with your physician, because some of the issues with it are that your muscle also gets weak when it's been in a cast for a long time. So when you return to trying to stand and walk again, you're going to need more rehab afterwards to regain that strength. And then there are other ways that you can try. So I think it depends on a lot of different factors, like how much spasticity you have, what the cause is of the reason for the loss of range of motion, because there are some places that will do what we do, kind of where we can split a cast in half, which would like allow you to take it off in order to bathe, each day and then replace it. Or you can use a brace similar to this with different plastics that can make it harder or not. I guess the weakness with those things is that the more about you're able to move within a splint, the more you're at risk of having skin breakdown. And we really don't want to cause some sort of a wound or a problem if that's an issue. So I think it's a good question, and I think it's worth talking to a provider who does it frequently that can give the best input. Thanks, Kathy.
No. Okay, keep on going so I can see.
Sorry. So what can you change about your environment? So we all know that there's a lot of different assistive devices out there that we can use. And, starting with hiking sticks just to get people out more, working over uneven surfaces. You can use those inside too, with the tip that covers the point. There's a lot of walkers that you can choose from out there. I think this one, the Rollator walker, is very common. But there's these other walkers that I'm showing here. So like this one that I just put up where you can rest your forearms, that might help give you a more upright posture. There's this one that you walk in front-wise so that you don't have to worry about your feet kicking the wheels, and it might be able to let you get up to your kitchen a little bit easier and work with your hands without having to hold on to the walker at all times. This one I haven't actually seen, but I would love to see it. It actually goes up and down curbs and over uneven surfaces. It has like a suspension like you might find in your in a mountain bike. And then there's a walker called the U-Step, which is actually more frequently used in the Parkinson's population, but it's heavier, so it's harder to just knock it over. So if you have a hard time, if you have a tendency to knock over one of these other more standard walkers, then that might be an option. And then lastly, there's your cane. And I famously learned from one of the people in one of our studies that your cane height should, if you are a golfer, be the same height as your putter if you were to turn it upside down. It's at least one good starting point, but there's a lot of cane options out there that you can choose from.
And Jen, there's a question about for children, for like a 2-year-old, what kind of walking devices would they be similar? Because these are all showing adults.
personally, but I know that all pediatric therapists have their sort of choice, and it does depend on the child and what the walking impairment is. We're much more commonly use these reverse walkers, we call them, or a posterior walker. And the nice thing about the ones for kids is that they allow some strapping to help with aligning the hips and the pelvis, and they usually have more attachments. If there's problems with like scissoring when walking, we can do a lot of other things. They also come in fun, cool colors, which I think should happen for adults as well. But for kids, there's a little bit more variety. So you can have ones, those also are nice because you can set them that they don't roll backwards on a child. So it helps them move forwards. The other thing that's kind of a nice thing to get a really young child moving, there's a program out of Delaware, actually.
Go Baby Go.
Go Baby Go. Thank you, Kathy.
Mm-hmm.
And they offer ways to modify common toys that kids might ride on, toys and things, to give kids more accessibility to their environment. And what they actually do is just provide you the way to go about doing it yourself and building it yourself. So that might just be another option too, of something to look into that makes mobility more fun for a child.
Great. Okay. Good. So making your home, I'm not going to belabor this too much because I feel like I've talked about it a lot and there's a lot of questions waiting for us, but I will tell you, it's really important to pick the chair that you will be going into. So if, for example, there's this nice comforter, really comfortable chair, but it happens to be very low, which does happen in many of the really soft, cushy couches, that's going to be really hard to get out of. So either choose a different chair or be aware that that's going to be difficult to get out of, and make sure you have a strategy. Make sure there's someone there that can help you get up, or you can use a pillow behind you so you don't sit quite as far back. Again, being aware of the situation and trying to plan ahead can make your environment safer for you and for the people around you. Falling is such an important thing. So you want to make sure that you don't put wires across the floor. You want to make sure that you look on the ground and make sure there's no water on the ground, because you can slip so easily. Again, taking away those throw rugs that you can just trip on so easily. I've even had some people who really didn't want to get rid of their rugs, and they used double-sided tape to make sure that the rugs didn't roll up, because you know how they kind of roll up in the corners sometimes. That could help. So in terms of just looking around your home, thinking about it consciously, what are some ways that I can make this environment safer? Can I put grab bars along my hallway so that if my walker doesn't fit, because it's such a narrow hallway, at least I have something to hold on to. In my bathroom, the most dangerous room in the house, I say, because there's water, everything, all the surfaces typically are very hard. You're not usually wearing a lot of clothing, so getting help can be a little bit embarrassing. Make sure there are grab bars there. Make sure you have a grab bar for your toilet. Maybe even have a bathtub seat so you can sit down and bathe instead of wearing yourself out, just so that you can have a shower while standing. Okay, go ahead. That I could go on and on, but I feel like just look at your home and try to think about ways that you could avoid falling. What are some things that you could do simply? Now, I think a main message that we want to get across here is that we want everyone to be able to exercise. I saw that one question came through, what are some ways to exercise if the disease is progressing? And so, whatever, so physical therapists and occupational therapists can kind of help adapt some of the ways that you exercise so that anybody at any stage can get some exercise. But it's really important. We think of this more with children, but I think even with adults, the way you stick with things is if you're enjoying it. So exercise needs to be fun at any age, at any stage of a disease, at any level of disability. Try to increase your activity, but keep in mind that we want to keep it fun so that you want to keep doing it. And our summary, we really think that exercise is medicine. So we're not saying go off medications that your physicians have prescribed for you, but we are saying see if your exercise can be done in conjunction with that intervention. So you take your medications, but see exercise as a very specific way of improving your function. One way to do that is to identify who your rehab specialist is. So Is it a PT? Is it an OT? Is it your physician? Is it a nurse that's near? Identify who in your area can be your best rehabilitation specialist. Identify what your limitations are. Are there sensory changes that you're experiencing? What muscles are weak? And which ones have maintained some strength? What is your mobility status? Do you need a walking device? Do you need a walking device just to exercise, but you don't really want to use one throughout your day? Or do you need a walking device all the time to maintain your energy? Really important to individualize your program. Now, we have been talking pretty extensively about AMN walking rehabilitation and really focusing on our study that showed that strengthening exercise were overridingly the most important element to improving walking for someone with AMN. But with other leukodystrophies, that may be very similar, but we don't know until you have been evaluated. So you first of all have to identify what your limitations are using the right rehab specialist, and then individualize your program to match those limitations. And we just want to say, get started as soon as you can. Even though we're in a pandemic, there are ways to use tele-rehabilitation to your benefit. And we're here to answer questions. I think that's our last slide. Maybe go one more and let me make sure.
I don't think so. I think that's it. I want to thank everybody who participates in our studies. We really appreciate that. It really means a lot to us, and it's how we learn to help you the best. And we want to thank Keely and Bob for inviting us today. We really enjoy being with you and having this chance to talk to you about what's been important to us in our career and in helping people and their families improve.
Definitely. I ditto that. And I've been reading the questions. So one question came up, how do we know what exercises to do? And can we, how do we get more information? So the paper that I talked about, I can provide to Keely, and we can make that available to everybody. And that's something you could take to a provider and get more information about. Another thing that people were asking about is alternative means of strengthening. So Jen, do you want to talk about Bioness a little bit as an alternative means of strengthening?
Sure, that's one possible way. I actually may have a slide I can show you, but I don't have I'm afraid I don't think I have a picture of a Bioness, but a Bioness is an electrical stimulation device. There's the Bioness, and then there's something called the Walk Aid. They attach below the kneecap, and sometimes they have an attachment that goes in your shoe. And they can also, where they basically help you activate your foot so that you can lift your toe up and clear your foot when you're walking. And in one gentleman in particular who I've worked with, he was 40 years old when I first saw him, and he was walking independently but slowly, so 1 meter per second, and normal walking speed is 1.4 meters per second. So he was interested in this device. He didn't have any real movement for moving his foot up when he started, and he got one of these devices, which they are expensive, and some insurance will cover it. That's something you have to kind of work at, but it's becoming more widely covered, I would say. But a year later, in that same foot that he was using it in, his strength went from 0 to 33 pounds of dorsiflexion strength on that side. And that was a dramatic improvement. And we found at that 1 year follow-up that he had a decrease in his dorsiflexion strength to 23 pounds at the end of that year. And so he went out and got a second one for his other leg in order to maintain that ability to lift his foot and swing his leg, to help him swing his leg through and clear it for walking. This was really significant. I guess I think there are a lot of things to think about with this as well. I think Kathy mentioned, but and I saw a question about it, about what vibration is. So sensory loss changes in AMN come in different ways. So you can have vibration sensation loss, which travels along your spinal cord, and it's the reason why we look at vibration sensation isn't that normally we wouldn't necessarily find vibration itself to be important, but it's a marker that the pathways that carry the information about where your foot is in space that helps you stay balanced, they're on the same pathway. So it's a marker, it's kind of it's a surrogate to tell us how is that pathway working. And it tells us that you may have a hard time knowing where your foot is in space, so you might trip over it, or you might not know and that you're losing your balance until you've gone a lot further than normally. But you can also have some peripheral neuropathy, so a decrease in your ability to feel due to nerve loss that's in the leg, not in the spinal cord. And when that happens, sometimes a device like the Bioness or the Walkaid may not be as effective at being able to activate the muscle. The other option at that point might be something called electrical stimulation for which you can use that actually directly stimulates the muscle and will help improve strength. And there are a number of functional ones out there too as well that are other means for doing it that are more high tech, but often require you to come to the clinic in order to use. And then I guess this other thing that has been brought to my attention recently is something called original strength. And I don't know if anyone is familiar with that. I think I apologize for flipping through my slide for a second. But this gentleman has designed this program that is for the general community that is about using movements that we do every day and that we did as we were learning and growing and learning to move, and using those in a repetitive motion in order to get stronger. So I often recommend people do you just use your everyday activity to get stronger. And this is basically sort of what he's advocating for. So we can do that too, whether we don't have any signs of weakness or sensory changes, or we do. So I think it's a matter of using something that you can do now and repeating it and maybe making it a little more challenging. So just try taking 3 minutes and rolling to your side in the bed and rolling back to your back and rolling to one side and rolling back to your back. You'll be surprised how much you have to use your core muscles, how much you have to coordinate your arm and your leg movement. And if you're paying good attention to your body mechanics and your form, you might find that you tend to let your head lag when you're going, and maybe that's a cause of some neck discomfort, and maybe you can start paying better attention to the way you move. You can also use rolling or coming from laying down to coming up to sitting. That makes you use your abdominal muscles even more. And then going back down, it makes you use your legs to lift your leg muscles, your muscles to lift your legs back into bed. That can be 70 pounds of effort that it takes to lift your legs. So maybe doing that, maybe with a little bit of assistance, repeating that over and over again, see how many you can do in a minute, and then work from there and try and increase that, either by lengthening the amount of time that you take, and you do it for 5 minutes and you just kind of space it out. So you're doing them with a little bit of a break in between, or maybe you try something like, I like to do sit to stand. If you just try going from sitting to standing as many times as you can in a minute or in 3 minutes, one way you can make that more challenging or easier or harder. So easier would be, say, doing it from your bed, which is a higher surface. It's easier to stand up from there, and then slowly lowering that surface. So one device that we use in the lab a lot actually is your bath chair, because it's really easy to lower that by 1 inch at a time by just adjusting those legs. So you can start up really high, and then once you get good at the, say, 22-inch height, you can lower it another inch and then start doing sit to stand from there. It's simple and it's easy, and you can do it every day at home. So that's just one suggestion.
Another thing that came up that I think maybe we could talk about is, how do you get a physical therapist, for example, who comes into the home? How do you get them to stay for longer? They tend to come for only a couple of weeks and then they leave. So are there strategies that I can think of some things, Jen, but why don't you start, and then I'll add if you haven't thought of the things I can think of.
I think that there's a number of things to consider. So one is, so as therapists, we have to try and help you reach a goal, and we can't just always work with you just to, we can work to help maintain things so that you're not losing skills. That's something that's becoming more widely acceptable for insurance coverage to cover that. But at the same time, it has to be something that you can't do yourself, or your caregiver, or someone can't help you with at that time. So that's one thing. So one thing to think about, I always think, is you need to figure out what what goals it is that you have. I mean, maybe you need to change your goals and think about something slightly different that you want to work towards. You may have to work on getting a little bit more creative about, those incremental changes that you're looking for, so that people, have something to work towards. So that that's one way, I think. Maybe also asking to spread that therapy out. So rather than getting 3 times a week of therapy at the beginning, maybe you ask instead, I would rather just spread this out to once a week over 6 weeks rather than 3 times a week for 2 weeks. And then, so home care is also different, and there's a lot of different, models. I mean, now with tele rehab, you may actually be able to get what would be considered outpatient therapy in your home through telemedicine. That means that the person wouldn't come to your home, but they can give you through, a web-based program, a way to do exercise and help you do that through supervision in that manner.
Right. I was thinking the big thing is, I think you have to communicate and find a therapist that is interested in doing this and interested in and understands your rationale for why you want this therapy to stay much longer. And because I think that sort of working together is really important. I think we have to stop too. I think we're
already
kicked off in a minute. Yeah. So there are several other questions. This is, I think if the ULF wants us to have another session at some point where we can answer more questions, that would be fine. But I really appreciate you joining us and listening. And I've written down these comments, so I'm hoping we can get to them in the future.
And if you want to reach out to Keely and have your questions sent on to us,
Right.
we would be happy to answer them directly. That would work as well. Thank you very much.
Thank you.